Anand TN, presently Professor and HOD, Department of Anaesthesia, Adi Chunchanagiri Institute of Medical Sciences. Sir has got more than 30 years of experience in teaching and research in anesthesia. 8 international and national scientific publications in the field of anesthesiology. His field of interest being flexible fiber optic bronchoscopy guided difficult airway management and labor epidurals. Other area of interest are music and singing. Over to you, sir.
Thank you, madam, for the introduction. Nice introduction. And good morning to one and all. A greeting from my institution, Adi Chunchanagiri Institute of Medical Sciences. First and foremost, there are only few pediatric anesthesiologists, I think, over here. And rest of are all general anesthesiologists who are doing pediatric cases. So we know that first and foremost, we need to recognize the distinct differentiation between the adult and pediatric population when it comes to technique of pediatric anesthesia. And in an attempt to understand the setup and the instruments and the equipments we use, I think one must appreciate the following things in pediatric age group. The first and foremost, children do not understand the importance of lying still for any procedure. Either they need deep sedation or they need general anesthesia. And not able to communicate or differentiate paresthesia or pain or pressure on injection. This is very important when we are injecting some drugs into the nerves, causing neural damage. They will not be able to appreciate and inform us because they will be under either deep sedation or under general anesthesia. Anatomical structures are very smaller and situated more closely to each other. And target nerves are very superficial. Of course, we need special equipment or probes like SLA array probe with pediatric application. Availability of this probe even is very difficult in all the setups. And lower concentration of plasma protein binding is also very important when we look into the pharmacokinetics of local anesthetic drugs. So let us understand what is anatomical and physiological consideration. So termination of conus medullaris is at L3 and L4. So it's better to do lumbar puncture always below L4. We should be very much familiar with the anatomy and the physiological aspect of pediatric anatomy. Termination of dural sac is at S3, S4 in neonates. So we should be very careful when we are considering caudal approach for caudal epidurals. We are likely to injure the dural sac. And curvature of the spine, the single spinal curvature with high degree of flexibility in neonates and absence of lumbar lordosis like adults will take the drug higher up. So vertebrae are very cartilaginous in nature, and when we are using sharp needles, the needles are likely to pierce the soft vertebra, and we are going to damage the ossification centers. And also, it will become intraosseous. The drug will be administered into intraosseous route because of this nature of vertebra. And CSF volume is 10 ml per kg in neonates, and turnover is very faster. So there will be dilution of drugs, what we inject into the subarachnoid space. And vascularity of diameter is very high. So it will take up the drug very faster from the site and leads to a manifestation like local anesthetic systemic toxicity. And epidural fat is very fluid up to 8 years of age, and myelination is complete at birth. This is very important because of the smaller diameter of the nerve and myelination being very at the immature state. Even low concentration of anesthetic agents are likely to land up in a dense motor block. And endoneurium in developing nerve is very loose, and it is easily penetrated by local anesthetics in both directions. So there will be faster onset of drug action and faster wearing out of drug. So pharmacokinetics in pediatric age group, local anesthetics have a greater volume of distribution. We know because the total body water and extracellular fluid volume is more in neonates when compared to the total body water, and lower clearance and high free non-protein burn fraction. Large volume of distribution counteracts the increased potential for toxicity caused by larger free non-protein burn fraction this will hold good for the amount of local anesthetic used for single shot procedures. But when we are planning for continuous infusions, the situation in the developing age is much more complex. The maturation of metabolism has to be taken into consideration. And immaturity of the enzymes which metabolizes local anesthetic agent is also a concern in the age group. And not all patients are ideal for regional anesthesia. In pediatric age group, they need proper selection, and careful selection is very important. Just like any other normal evaluation of pediatric age group, we need to rule out the associated neurological, existing neurological deficits or injuries or any other congenital anomalies. Careful consideration is given to the behavioral tendencies when the block is given, when the block is offered as a sole modality of anesthesia, because at any point of time we can expect complications related to neurological procedure. In that way, we should be always ready for combating the situations, and we should be always ready with all equipments and other things to consider general anesthesia in these patients. There should be well-trained nursing staff to recognize the complications in the post-operative ward, and to console the patient, console the awake child. Because of regional anesthesia, the child may not be able to move. Child may be awake or not able to move. So child needs some reassurance, consoling. One should be able to console the child. And use of peripheral nerve stimulators. Of course, peripheral nerve stimulators, when you look into the needle nerve recognition, the sensitivity is not high, but the specificity is high. So ultrasound usage, of course, we need special probes. And literature says additional level of safety, but still insufficient evidence to support this. And consent, always we should speak to the patient attendants and bystanders and parents and get the consent after discussing with the pros and cons. And serious complications like convulsions, cardiac toxicity, spinal cord, nerve injuries leading to paralysis, neurological deficits, pneumothorax, hematoma, infections, including the cardiac arrest and death must be disclosed. Although half of the anesthesiologists routinely disclose this kind of risk. And most probably, if you explain all this risk, I don't think the parents will definitely agree for regional technique. Steps involved in performing the block must be explained in age-appropriate language. And reaction to preservatives, of course, has to be bear in mind. We should bear that in mind that methyl paraben or metabisulfite or allergic reactions are also common to local anesthetic agents. So systemic toxicity presentation can be vastly different because the pediatric population usually will be under sedation or GA. The first sign may, in fact, the dysarrhythmias, first sign itself can be a cardiac manifestation because most of the CNS manifestation will be masked by either sedation or general anesthesia. So hypertension can be a first manifestation or even the cardiac arrest can be the first manifestation. So ability to detect inadvertent intravascular injection of local anesthetic agent is also altered. Resting heart rate is too high, and the bolus dose of local anesthetic agent with epinephrine does not increase the heart rate. So it is very difficult to predict the intravascular placement of catheters. There are early reports that use of lipid emulsions may stop seizure activity in adults, not yet been reported in pediatric population. And I don't know how many of us are having this intralipid emulsions in hand to treat if any such complication arises. So direct toxicity to neural structures can be direct needle injuries or ischemia from embolized air as a result of loss of resistance to the technique, to the air. Our ability to detect neural injury is also lower in children. Cardiovascular toxicity is the final step in the presentation of local anesthetic toxicity. So presentation can be sometimes only the ECG findings and even the cardiac arrest. So equipments related complications. Neural injuries, again, detection is very diminished in young and immature nervous system. And it is able to, because if there is any injury also by needle, the immature nervous system is able to adapt to the injury over a short period of time, and it can get even recovered faster. Intraneedle injections goes unnoticed, and small gauge short blunt needles are recommended, special needles are recommended to do blocks in pediatric age group. Always maintain low injection pressure by using compressed air injection technique if it is available, or inline pressure monitors. So these are very helpful in maintaining low injection pressure in any compartment to prevent the nerve injuries because of mechanical effects. So considering the potential of nerve injury to impact on the quality of life and precipitate litigations, the second ASRA practice advisory on neurology complications associated with regional anesthesia and pain medicine has put forth extensive evidence-based practice advisory regarding patient factors, choice of anesthetic, intraoperative blood pressure maintenance, surgical factors, diagnosis and management of perioperative neuraxial and peripheral nerve injuries. Earlier, the intraoperative blood pressure, the mean arterial pressure was published as 50 mean arterial pressure has to be maintained to prevent spinal cord hypoperfusion. Now, the recent guideline says to maintain it around 60 to 65. Again, needle trauma to the spinal cord. Should it occur, there is no specific treatment for primary needle damage, primary needle damage to the spinal cord. We have to rule out the reversible causes of cord injury like hematoma, and even then we have to go with the proper investigation, and early diagnosis is very important. And if there is any hematoma formation, it needs to be decompressed within 5 to 6 hours to prevent permanent damages. Risk of pneumothorax is difficult to quantify. Of course, the incidence is about 5 to 25%. And recommendation regarding epidural test dose in pediatrics by joint American Society of Regional Anesthesia of Pain Medicine and European Society of Regional Anesthesia of Pain Therapy. So regarding test dose, they say it is discretionary. So any partially administered dose of epinephrine or GA can blunt the response and give a false negative result. Better thing is to give the injections of local anesthetic slowly in a small liquids, 0.1 to 0.2 ml per kg, and with intermittent aspiration. After the injection of test dose of local anesthetic agent with epinephrine, any change in T wave or heart rate variations, rise in heart rate within 30 to 90 seconds is regarded as intravascular placement of the catheter until proved otherwise. So these are the level of evidence quoted by these studies. And if you look at the board of association, British Orthopedic Association of Standard of Testing in 2014 documents acute compartment syndrome as a surgical emergency. Children are more vulnerable, and they are more vulnerable, and they are unable to express and distinguish between the surgical and ischemic pain. So this is where this can go unnoticed, and symptoms like pain, paresis, and paresthesia can manifest if the child is awake. Otherwise, it goes unnoticed. Gold standard for diagnosis of intracompartmental pressure monitoring is monitoring of the pressure within the compartment. The normal pressure is about 10 to 12 millimeter of mercury. Patient can manifest with pain if the pressure exceeds 20 millimeter of mercury, and any pressure exceeding 30 millimeter of mercury is an indication for emergency surgical indication in terms of urgent fasciotomy within 1 hour. So the recommended lower concentration of local anesthetic agent always, and restriction of volume. And adjuvants in pediatrics, I think FDA has approved only clonidine, 1 to 2 mics per kg, and morphine, 10 to 30 mics per kg for intrathecal use. And dexmedetomidine can be used in neuraxial and peripheral nerve blocks, but minimally necessary dose should be used. And that is the level of evidence quoted. And when you look at the safety data, the Pediatric Regional Anesthesia Network has conducted, is a collaborative group of pediatric hospital which acts as a registry for regional procedures in pediatrics. So recently, Pediatric Regional Anesthesia Network did a multi-institutional study in about collected data from 20 institutions and from 2010 to 2018, and prospectively analyzed about 1 lakh blocks. In this study, they did not identify any permanent motor or neurologic deficit, definitely, but infections reported with catheter used for higher number of median days, like 4.5 against 3 days compared to 3 days. And here, the common adverse event they have come across is catheter failure. And the common adverse complication they have come across is malfunctioning of the catheter. But data demonstrate, of course, the level of safety in pediatric regional anesthesia and confirms the safety of placing blocks under general anesthesia in children. So, the French Language Society of Pediatric Anesthesia published the results of 2 audits performed approximately 10 years apart in 1996 and 2010, and the complications were rare, 0.12% and minor, and none resulted in sequelae. But when we look at this publication in one of the journals in 2012, a report of 4 cases of ambiguous etiology associated with epidural anesthesia in children. These 4 cases illustrates severe permanent or long-standing neurological injury after uncomplicated placement of an epidural catheter in children by experienced pediatric anesthesiologists. 3 cases resulted in feasible medical malpractice claims and settlement despite the absence of proof of medical negligence. No evidence of direct trauma in all cases. There was no evidence at all, even by radiological evidence. But 1 in 3 out of 4 imaging studies shows vascular injury to the cord, compromising the perfusion to the conus medullaris. In case of, in one case, it was suggestive of neurological toxicity. So, experience concluded that from these studies that these cases that ischemic injury to the spinal cord may occur in children even during epidural anesthesia. Collection of outcome of data for large number of children undergoing epidural anesthesia is necessary to define the magnitude of risk. Further, laboratory and clinical investigations are desirable to define the pressure-volume relationship in epidural space and these effects on transient epidural hypertension on spinal cord and its blood flow and perfusion to guide appropriate local anesthetic volume and rate of injection as well as safety adjuvants in developing central nervous system in children. So when we look at the Indian perspective of safety monitoring of local anesthetic drugs in India, there is a National Coordination Committee for Pharmacovigilance Program of India, which monitors adverse drug reactions among Indian population and helps the regulatory authority of India. Here, in taking decision for safe use of medicines, here in this program, it has become a formidable force at international level with the best pharmacovigilance practices, including adverse drug reactions reporting and providing skill development. Little is known about ADAS locally in India because we are lacking in reporting any adverse event that is happening in our setup or in our experience. All the healthcare providers are urged to report the ADAs due to local anesthetic drugs, as they may contribute for the emergence of new disorders or reactions. Their toll-free number is also given in the form of 1800 180 13 and 24. Anybody who gets adverse reaction, who come across adverse reaction, can report to this pharmacovigilance program of India. And to conclude, data from a diverse group of children hospital like PRAWN demonstrate that regional anesthesia in children is a safe practice, including performing the neuraxial and peripheral nerve blocks under general anesthesia. Although there were no serious neurological complications reported in these studies, some case reports do exist describing permanent injuries. So systematic training, the right equipment, a knowledge of anatomy, understanding of local anesthetic drugs, and vigilant monitoring, training in ultrasound regional anesthesia, and an attitude of keeping abreast with latest information goes a long way in improving the safety. And these are my references. Thank you.